The main function of all valves in our body is to maintain a unidirectional flow of blood. Unidirectional, it means blood coming from the right atrium should not ever go back to the right atrium from the right ventricle. It should flow from the right atrium towards the right ventricle, no backward flow. This is the job of the valves. Now let's talk about the right atrioventricular valve, or the tricuspid valve, so named because it is usually consists of three cusps or leaflets. The bases of the valve cusps are attached to the fibrous ring around the orifice or the annulus fibrosus. We did, if you remember, mentioned that the fibrous skeleton. We did mention that the heart has not only endothelium, myocardium, and the epicardium. It has also inside it, within its structure, a fibrous skeleton. And we did mention that the fibrous skeleton provides the orifices, helps in muscle attachments, providing pathways to, for example, the AV bundle, insulation of electrical or conducting system. So there you go. Here, as you can see, the fibrous skeleton provides provides what it takes for the cusp to be attached to this annulus fibrosus. Now, its orifice is best seen from the atrial aspect. Here, if we remove the atrium, or we are in the atrium now, we can see this orifice very clearly, as you can see it here. Now, it is huge relatively, this orifice, 11.4 centimeters, large enough to admit the tips of 3 fingers. It is almost vertical, but at 45 degrees to the sagittal plane. What does this mean, vertical? Now, if you look at this picture here, in this picture, the heart, it's not in the anatomical position. It's rather like the apex is completely down and the base is completely superior. I did that on purpose. Now, if the blood had the heart was lying in our body in this position, the blood would have easily come, of course, from this area, from the atria, in this case the right atrium, downward to the right ventricle. If we to draw the direction of this valve, it would be totally horizontal, like this. Now, we know that this is not the case, and therefore when we put the heart in its anatomical position, you can now see that the heart, the tricuspid valve, is vertical in its position. It's rather this way here, in this way. So it is vertical and it's not horizontal, bearing in our minds that the right atrium almost posterior to the right ventricle. What else? The atrial surface of the atrioventricular valve is rather smooth. The ventricular surface is irregular because of the insertion of the chorda tendini. We will talk about this as we proceed and talk about the histology of the cusps themselves. Now, this is again to highlight the fact that the tricuspid valve is vertical in its anatomical position. The atrioventricular valvular complex consists of the orifice and its associated annulus plus the cusps, which are supported by chordae tendineae, various types of the papillary muscle. I would take you to this picture here. So the tricuspid valve and of course the mitral valve, they have the same structure with different numbers of course the papillary muscles and cusps. However, the structure is the same. So we do have any valve should guard an opening. So the opening here is this. Just the opening is provided by fibrous annulus. So there is a fibrous ring to start with. You can't build a door without putting first of all for this door a frame. So we have a frame and we have a door. Here also we have a frame, which is a annulus fibrosus, as we mentioned, and now to this frame we would attach the of course here orifice and associated annulus. We did mention that this is the first part of any valve. Even the mitral valve would be at the same would have the same structure. Now let's go back to this drawing here. So we said that we have the annulus fibrosus, so we have the frame for the valve, so it's not muscular, it's fibrous. So we did build here a frame for the valve. Then we would now guard this orifice by means of the valve, which is in this case the cusp, and to each cusp chordae tendineae, and of course with associated papillary muscles. So we can here go through them. This is the papillary muscle, one of them, chordae tendineae here, and eventually this is the cusp, which is attached to the fibrous annulus here from the fibrous skeleton of the heart. So we have at least two major components for any given valve. That is the fibrous associated annulus of the orifice, and the valve that guards this orifice, which is made out of course cusps here, chordae tendineae and papillary muscles. The tricuspid valve consists of three cusps, and that's why we call it tricuspid valve. They are, as you can see in their direction, this is anterior here and this is posterior. Now this one would be posterior for sure, and this one would be almost posterior, and this one to the wall. Here is the interventricular septum, so it is to the septa, and we call it septal. So three of them, anterior, posterior plus septal. More on the structure of the atrioventricular tricuspid valve. The bases of the cusps are attached to the fibrous ring. This is the base of this cusp, this is the base of this cusp, and this is the base of another one, to the fibrous ring of the skeleton of the heart. So this is very important to understand, that the cusps themselves themselves are attached to the annulus fibrosus, to a fibrous skeleton, not to the myocardium directly. This not gonna take place here. It's rather to the fibrous annulus fibrosus. Now, however, their free edges, as you can see here, these are attached to the chorda tendini, and the chorda tendini is attached to papillary muscle. So why we are talking about the components of any valve? We do need to know the components and the detailed structure of the valve, because each one of them can be affected in its way. The annulus fibrous by itself can be affected, can be damaged. The cusp by itself can be damaged, the chorda tendini. So all these structures are associated with the valve. In fact, they're making the valve, and any damage to any one of them would affect the work of this given valve, which is the maintenance of one unidirectional blood flow. If the valve gets any problem with any of its components, of course, the patient would develop problems associated with the backflow of the blood from one chamber to another chamber. Now, under microscope, if we to take the valves cusps, we would find them made out of 3 layers. First one is the spongiosa, the second one is fibrosa, the third one is ventricularis, of course, and you should know that the cusp itself here is covered by endocardium. Now, what is important about them, that spongiosa is loose connective tissue located on the atrial or blood vessel side, aortic and pulmonary. The fibrosa, so this is the one that facing the cavities. The fibrosa forms the core, the middle part of the cusp. It is dense irregular connective tissue of the skeletal attached to the skeletal rings of the heart. And finally, the ventricularis, which is immediately adjacent to the ventricular surface of each valve and is covered with endothelium. It contains also elastic fibers. So if I to reflect on the structure of the cusp, they are very fragile. They are mainly core of fibrosa covered by a little bit of spongiosa and of course the ventricular surface, which is covered by endothelium. So in all cases the cusps are not complicated in their structure. They are not thick, but they are rather thin. Now, a clinical application about the cusps, which is very important, and I would always ask about it in your exams, because of this might be the most common cause of problems or diseases in the heart. One of them. Valve cusps are normally avascular. This is very important. They are avascular, except maybe near their bases, where they can get some blood. But because they are thin, they can be supplied by diffusion from the blood that it bathes them all the time. So, because of their unique structure, sometimes if patients they get rheumatic fever and this may cause inflammation of the heart valves, valvulitis. Inflammation induces angiogenesis in the valve and vascularization in the normally avascular layers of the valve. So we mentioned that the cusps are avascular except for their near their bases, and if they get inflamed, they would become vascularized, and the process of angiogenesis would take place. What does this mean? These changes during inflammation most commonly affect the mitral valve 65 to 70%, and aortic valve for 20-25%. So most likely the mitral valve, this inflammation can lead to progressive replacement of elastic tissue by irregular masses of collagen fiber, causing the valve to thicken. The valves become rigid and inflexible, which affects their ability to open and close, and this would affect their ability also to maintain unidirectional blood flow. Interesting why the mitral valve has been affected more than other valves, because the mitral valve, especially its anterior cusp, is subjected to two currents of blood, one coming from the left atria towards the left ventricle, and from the left ventricle towards the aortic valve. This area here is very sensitive, which is the anterior cusp of the mitral valve, and it can be affected. So that's why the mitral valve is more involved than other cusps or valves in terms of valvulitis. The extreme edges of the cusps are thin and delicate with sawtooth appearance. This is the free edges, so tooth appearance, from the insertion of chorda tendini. Of course, away from the edge, the atrial surface of the cusps is finely nodular. The nodule particular is small in children. These nodules are called the noduli albini, and they are used to tightly close off the cusp up on each other to prevent backward flow. The noduli albini, they are small fibrous nodules on the margin of the mitral and tricuspid valve of the heart, as you can see them here. This one, this one, this one, this one, this one. They would be associated in the closure of the valve by becoming intermingled with each other from different cusps to tightly seal the, of course, physiology of the valves. I will not talk about it in details, of course, but at least I would help you to understand more the way the valves are working. Now, when the ventricle contracts, the papillary muscles contract and prevent the cusps from being forced into the atrium and turning inside out. The interventricular pressure raises as the interventricular pressure raises. To assist in this process, the chorda tendini of one papillary muscle are connected to the adjacent part of two cusps. As you can see, this is one papillary muscle, it is connected to this cusp and to the other cusp. So when the papillary muscle is contracted, it won't just uh, affect this one, but would affect this one. It would act on both of them. If we would take it the other way around, for example, the papillary muscle is attached to only to one cusp, that would mean that in any time that there is no coordination between the papillary muscles, one of the cusps will prolapse. What does this mean? Goes back towards the left, towards the atria. On closure of the atrioventricular valve, the narrow border between the row of Albini nodules and the free edge of each cusp presses against that of the next, resulting in the secure watertight closure. So as you can see, this is the final view of the closure of the valves. They are tightly attached to each other by means of these Albini nodules, and nothing can go backwards from the right ventricle towards the right atrium. Chordae tendineae are fibrous collagenous structures supporting the cusps of the atrioventricular valves. Tendinous cords attached to the free edges and ventricular surfaces of the anterior, posterior, and septal cusp, much like the cords attaching to a parachute. There is always a question about the function of papillary muscles. If you look at the papillary muscles and their structure, attachment to the cusps through the chordae tendineae, as it is here in this diagram or in this picture, you may think that the moment the papillary muscle contracts, it would pull the chordae tendineae towards its attachment, and it would open the valve. This is not true. The pressure gradient would open the atrioventricular valve when the blood is pumped from the right atrium towards the right ventricle. It is the pressure that opens the cusps, because they are designed to be opened inside the, of course, the cavity of the right ventricle. So let's agree upon one fact. There is no doubt about it. Papillary muscles, they can't open, and they will not open the valve, but they would rather tightly secure the closure of the valve. How? Look at this picture here. It's when the blood has become inside the right ventricle, and the blood is just about to be pumped towards the right towards the pulmonary trunk, so out of the right chambers. The pressure is huge, and it would try to go backward to the right atrium, whereas the pressure is much lower. And this just in this moment, at this time, the chordae tendineae, the papillary muscle, would contract, and they would do the opposite to what you think. They would prevent relapsing of the these cusps inside the right atrium. So they would be attached to their myocardial sites by chorda tendini, they would hold the cusps from being pushed into the cavity of the right atrium. And what does this mean? It means that the valve is closed and the blood is not going from the right ventricle, whereas the pressure is high, towards the right atrium, whereas the pressure at this time of the cardiac cycle is low. So what is the main function of papillary muscles? They never open the valves, they rather ensure the competence of the valve. They secure the closure of the valves themselves, because the cusps are designed to be pushed by the blood, but they may go inside the atria, so they need something to keep them tight and in their places, and this is the function of the, of course, papillary muscles. The mitral valve has the same structure as the tricuspid valve, but the number of cusps here are two, anterior and posterior ones. The papillary muscles are two as well, anterior and posterior. Their size is larger. We did talk about this in a former lecture, so I won't go into details to explain the detailed structure of the mitral valve, but I would rather highlight once again the fact that the anterior cusp of the mitral valve is subjected to two currents of blood flow, the one coming from the left atrium towards the left ventricle, and of course from the left ventricle towards the aorta. So if we go behind it, we would see the mitral valve, and here it is opened, we would see the aortic valve. So it is right in between these two currents, and we did also in details explain everything about the direction of the blood flow in the left ventricle as it goes in 180 degrees, and this is exactly what I explained to you in the last lecture. So if we to summarize the valves of atrioventricular valves, the tricuspid and the, of course, the mitral, you would certainly notice that they are complicated in their structures. Annulus fibrosus, part of the fibrous skeleton to which is attached the cusps or the cusps, and of course to them are attached chorda tendini, tendini and the papillary muscles. They are guarding high pressure compartments, which is the right, in this case in the right atrioventricular orifice, and the left atrioventricular orifice, the left ventricle and the left and the right ventricle. So and that's why their function is huge, to not let the cusps go backward, prolapse into the atria, and that's why their structure is a bit complicated. Now you may understand this when we talk about the semilunar valves. The semilunar valves are very simple in their structure. No chorda tendini, no papillary muscles associated with these valves. The aortic valve guards the aortic orifice, and the pulmonary valve guards the pulmonary orifice. Now, we do also have for each one of them a circular ring of fibrous tissue. So this the basic structure in all valves is the same. We do have fibrous skeleton ring, and to that ring cusps. However, the only difference between the atrioventricular valves and the semilunar valves, of course, the associated chorda tendineae and the papillary muscles. Now, 3 is, of course, cusps also in the aortic and the pulmonary valves. We would see them, and they have 3 pocket-like cusps of approximately equal size. The atrial wall expands into 3 dilated pouches, the sinuses of Valsalva. So they are rather the cusps themselves. They are similar to a pocket, and that's why we call them sinuses. The cusps of the arterial semilunar valve are largely smooth here, of course, and thin. They are very thin and smooth. At the center here, as you can see, of the free margin, this is the free margin, whereas the attached margins are there. The free margin here of each cusp is a small fibrous nodule, the nodulus auranti. So one in the center of each sinus. There is one here, and there is another one here. On each side of the nodulus of auranti, along the entire free edge of the cusp, there is a thin half moon. This area, half moon, we call it lunula. It means the crescent shape of the moon, or one of the stages of the moon, lunula, that has a fine striations parallel to the edges, and that's why we call them semilunar. Lunar, it means the moon, half moon, which is hilal in Arabic. Okay, they look like it here and there. That's exactly for the pulmonary and the aortic valves. So the structure of the semilunar valves is just fibrous ring, cusps, and these cusps are 3 in numbers, and of course they form, instead of just cusps that are attached to chorda tendineae and to the base, to the fibrous ring, they are rather forming pockets, and these pockets close when the pressure gets back to normal in the wall of the aorta or the pulmonary trunk, and they fill the pockets with blood, and the pockets come together, this one with this one and this one, and they come together and they just close the orifice. And now this slide, I would talk about it in the embryology, in the development of the valves themselves, but I need, of course we're gonna go back to this slide, but I need you for now, for the time being, for the exam, to know that the aortic valve has 3 sinuses, as we mentioned. Their names, we will talk about their names later on, but for now, for time being now, let's consider them posterior non-coronary, right and left sinuses, and of course just superior to the right and left cusps in the sinuses of Valsalva are the openings of right and left coronary arteries. These are the right and left, of course, coronary arteries coming from the origin of the ascending aorta, where two of them opposite, of course, the right and left cusps or sinuses. The pulmonary valve has also three cusps. One of them is anterior, and the other two are right and left. Here we have aortic, one posterior, then right and left. Here in the pulmonary we have anterior, right and left. The same design in both of them, but from the pulmonary we don't have the openings for the coronary arteries. So during your practical session, if you open up a valve and you see openings, this means that this is the aorta, the aortic valve. But if you can't find any openings, it means this is the pulmonary valve. These two slides, this one and the other one here, or three slides, are not required in this course, so I would stop here